cerebral blood flow. Next slide. There are now several studies that show that antihypertensive treatment may actually reduce the risk of dementia. Keep in mind that these studies were done with a number of different techniques of measuring blood pressure, yet in aggregate, they all have similar results, that the treatment of hypertension might actually reduce the risk of dementia. This was just one of those studies called the COSMIC study. It's a meta-analysis of 17 studies from 15 different countries, representing over 34,000 community-dwelling older adults of mean age 72.5, and they were studied for a follow-up of about 4.3 years. And I'll just point out here that those with treated hypertension had no difference than those who were healthy controls in the risk of all-cause dementia. In the fully adjusted analysis, there was no significant difference between treated hypertensives and healthy controls. Yet untreated hypertensives, compared to healthy controls or those with treated hypertension, had a increase in their risk of dementia. So this just illustrates that the treatment of hypertension, regardless of how that's defined or measured, might actually improve cognition and prevent dementia. Next slide, please. The SPRINT MIND study had similar results. This was referred to earlier, and here a systolic blood pressure reduction to 120, representing intensive treatment, versus standard treatment to 140 or below, reduced the incidence of mild cognitive impairment by 19%. It did not significantly reduce dementia, but the combined endpoint of mild cognitive impairment and dementia was significantly reduced by 15%. So the treatment of blood pressure did not harm cognition, and generally what's good for the heart is good for the brain. Next slide. Here is a large meta-analysis of the various antihypertensive trials for their effect on dementia, defined in a number of different ways through specific criteria or clinical diagnoses or dementia with mild cognitive impairment. And in aggregate, the odds ratio was 0.93, which showed about a 7% reduction in the risk of dementia. Small, but significant. Next slide. Not only does the intensive treatment of hypertension reduce the risk of dementia in older adults, but it also reduces the progression of white matter hyperintensities, suggesting that in fact it may have an important impact on cerebral blood flow. And here you can see that at 18 months or 36 months, shown on the x-axis, the intensive treatment, shown in red, reduces the change in white matter hyperintensities at both time points compared to standard treatment. Next slide. Next slide, please. So the key points I'd like to make is that older adults, especially those with hypertension, have increased blood pressure variability that places them at risk of hypotension during common daily activities. Remember, the higher you are, the farther you fall. This, of course, creates all kinds of issues about what the threshold for hypertension would be, what the threshold for hypotension would be. But in general, hypertensive individuals, regardless of how it's defined, are at risk of hypotensive events throughout the day. Orthostatic and postprandial hypotension are particularly common in older people, and they're often overlooked in the clinical practice. Remember, they threaten cerebral perfusion and may result in cerebral microvascular disease and cognitive impairment. The treatment of hypertension may improve blood pressure regulatory mechanisms and prevent hypotension and its consequences. And therefore, blood pressure monitoring during activities of daily living, whether it be by a home-based method using a diary or by ambulatory measurements, should be done in all of our older patients, especially after meals, posture change, and medication administration. And this can help detect the circumstances, timing, and degree of variability of blood pressure and its response to treatment. Now, many of the monitoring devices that we use, particularly automated ambulatory monitoring, are not specific enough to look at the meal response, the postural change response, or medication administration. So it's very important that we be able to look in response to these particular activities. And averaging measures over time also does not enable you to pick out the changes that occur during these common activities. So I think it's very important to keep this in mind. Next slide, please. So the key knowledge gaps are shown in the left column here, and our future opportunities, some of the future opportunities we have on the right. The first gap is how to measure blood pressure continuously in response to specific daily activities. And then at what stage of cognitive impairment or frailty does blood pressure treatment slow or improve cognitive decline? Probably the treatment of hypertension in people already impaired with advanced dementia is not going to improve their cognition or cerebral blood flow or microvascular disease. But certainly early stage dementia or pre-dementia periods are key treatment opportunities. And we don't know which antihypertensive medications can improve blood pressure regulation, prevent hypertension, and preserve cerebral blood flow. So there are many future opportunities, which we'll be discussing during this workshop. We need to develop reliable, continuous ambulatory blood pressure monitors that have the ability to prompt patients for symptoms and time measurements at specific times we're interested in. I usually give my patients a diary to take home after instructing them on blood pressure measurement technique and ask them to fill out that diary at specific times of day and in response to specific activities. We also need to test the effect of different medications on cerebral blood flow, as well as brain structure and function, and ultimately conduct randomized controlled trials of blood pressure management on patients with and without different stages of cognitive impairment, using blood pressure variability, cerebral blood flow, MR imaging, and biomarkers as outcomes. So thank you very much for your attention. I will stop there.
Thank you for that wonderful presentation, and thanks to the whole panel for three great talks. We have about 15 minutes here for questions. Lou, I have a question for you. As you think about variability in the elderly population, do you recommend even more measurements before diagnosing hypertension or deciding to intensify in that population because of that variability?
I do recommend measurements. More is an interesting issue, but at specific times. I mean, as you saw on the graphs that I showed, many of our older patients wake up hypertensive in the morning. They have a reversal of the nocturnal dipping of the circadian rhythm. They wake up quite hypertensive, and all it takes to reduce their blood pressure is a meal. And after breakfast, many of them are relatively hypotensive. So if that's the case, maybe I'll just treat them with a meal. Some of them are hypertensive overnight because they have sleep apnea or other problems, so I might treat them at bedtime. So I need enough measurements to be able to define when they are hypertensive, when they are not, so I can adjust their treatment accordingly. And maybe treatment isn't even needed. And I don't need it every day. I usually ask my patients to take their blood pressures under those circumstances Monday, Wednesday, Friday for 3 weeks, and then bring the results to me, and then I can evaluate it in the office, make a decision.
Great, thank you. So question, there have also been a lot of discussion regarding non-adherence in routine care to guideline recommendations for blood pressure measurement techniques. I'm wondering, Tara and Joe, maybe if you could comment on the specific challenges. I think, Joe, you mentioned chairs, cup size, in your specific populations for what you see in routine care compared to what you might see in your own clinic.
I think one thing to just speak about in the pregnant and postpartum patients is and this is not to be disrespectful, but we're not a chronic care management or primary care clinic most of the time. And so the staff and the providers are not thinking about blood pressure technique. And so I've personally tried to do a lot at my institution of like, people just need to be sitting properly and follow normal hygiene, as well as there's a large recommendation of having people do out of clinic monitoring, but there's no instructions or teaching or investment, or the people that are doing them don't even know how to teach it. So there's really a lack of education, I think, on all levels there. Another issue is like if we have antepartum patients in the hospital, they're in beds, right? So people are not getting them out of bed to measure their blood pressures. And so I would just say like broad strokes across the pregnant population is a lot of education's needed, not only from outpatient, but inpatient, and standardization of just simply taking a blood pressure. And then another thing is we have a lot of obese patients, and the extra large cuffs are too long for their arms. I mean, there's lack of devices that fit well too. So those are just some immediate comments I have.
Yeah, and for children, we I mean, lack of adherence to technique could be either in the office or at home, right? And so we are pretty, of course, compulsive in our hypertension clinic to make sure we're doing things right. We there have been sort of large quality improvement efforts to look at this in general pediatric practices, and there's clearly some poor adherence to that, to all of the steps. And so, some things that potentially could, overcome that. I was interested to hear about that. You didn't need to wait as long before doing the measurement or wait as long in between. I think we need to look at that in children. That has not really been studied to my knowledge. Just, producing more educational materials and getting the word out there for general pediatricians. We do spend a lot of time with our patients, so our nurses have a structured way of teaching the patients how to measure their blood pressure, and that includes some, a handout and a review of how the device works and so forth. And we'll often sort of reinforce that when patients come back for clinic visits, especially when I'm seeing a big discrepancy between the home blood pressure readings and the office blood pressure readings. Like, did you actually sit down and rest for a while before you did that blood pressure there, Jose? And, the answer will often be no, and you do some education in that setting.
I'm really interested to see where we're going to go. And I think all three of you touched on the fact that there's a big implementation gap. And I loved at AHA Hypertension or AHA Scientific Sessions in November in Chicago, this came up constantly, maybe I'm biased, is that we have all these guidelines. We know what to do. We know what blood pressure is the target. We know what meds, but they're still not being implemented across the board, not even just in primary care, but for those of us who do this work for a living. And I am poster child for that. If I fail to do stuff per guidelines all the time, oftentimes it's not because I don't believe in them, but because I'm human and I forget, and we get really busy in clinic. So I'm curious for you all, how do we really transform the field by doing what you alluded to, Joseph, of empowering not just our patients or families like Kara did with her kids, but providers too, at all levels, right? Not just the physicians and the PAs and the nurse practitioners, but the MAs, the nurses, to really do these things, but in a sustainable way. The way we conceptualize it is we have to change the system, we have to change the culture, and we have to educate. So we have to make it stupidly easy for people to do these things, which really requires their buy-in to get that internal motivation that they're invested in remembering to do things and then making it a really easy system where it's automatic. They don't even have to think about it. And I don't have a solution. So I'm curious for you all, not an easy ask. What do you think we should do?
I might just make a comment. It's hard enough to get people to even pay attention to blood pressure, let alone measure it correctly. So I'm kind of happy if they measure it, even if it's not exactly right. And maybe that sounds a little bit off our topic, but I think we often err on the side of trying to make sure they don't have hypertension than diagnosing that they do. They come into the office, we're wearing our white coat, it's high blood pressure. Well, it's not just the white coat. I mean, there are other times of day, other circumstances in their lives when they're stressed. And so if their high blood pressure, if their pressure is high when they're stressed, I want to know it. Certainly position, timing, all of that are important, no question about that. But we keep taking the pressure over and over again until we find a value we like, which is usually a value that's normative. So it's like we work so hard to eliminate the finding of hypertension. And I would like kind of think, even though I'm a geriatrician and I don't want to treat everybody, too much, I think we shouldn't be so worried about somebody who comes in hypertensive. I think we should treat them and not worry as much about whether we're exactly right according to guidelines. Just a thought.
Some of my strategies are really about I think there needs, in my dream world, it would be like working with high level impactful organizations that maybe do CMEs and teaching and other things. And then some sort of incentive for this. I think pregnancy is one thing, but I think also the postpartum and transition to long-term care. I mean, if we can really help people understand, this is why our people in the US are dying, and if you can make an impact, if we can make it personal and make it really feel like they're really making an impact, maybe there's a way. But then I think, I don't know, easy tools, or I don't really have a solution, but I think that's a start, is really making it personal somehow. That's not really research, but or also ways for people who don't have time to do research to get the feedback of what they're doing is informing research. So could there be some way that we could include people in standard clinical care settings to provide data that knows they're really making a change or something like that? So anyways, buy-in and rewards. Maybe that's the way to success.
Questions from the audience?
This is Dick Dart up in Marshfield. I'm a clinician, many years in clinic practice, and I think all the comments made are very typical. I'm in a private practice. It's a large group practice, but I've been treated to the same thing where I go in and get somebody to take my blood pressure. They'll put the wrong size cuff on. They're talking to me and they want to run through things. And I think what Dr. South pointed out, they just, and it's on the wall. It's there, what you should do. And I'm like, what do you have to, I tell them, I said, I really like you to do this right. Not because I worry about hypertension. I have a little bit of blood pressure, but it's well controlled. But I think it's the issue of we ought to be more concerned about outcomes than versus the incomes, meaning the money you make for doing something versus the outcomes we're getting in terms of actually healthy, making people healthy or keeping them healthy. And I think that's a very difficult thing to get across and get to people to get in the habit of doing, measuring blood pressure correctly.
Yeah, if I could just comment, there's a question from Tammy in the chat also about what should we do to improve cardiovascular health in youth. And, I think it does begin with simplifying the recognition of hypertension, providing people with tools for detecting it. And then, we have the big question in pediatrics of not really knowing the best mode of treatment. And so, figuring that out. And that's not the focus of this workshop, but, understanding whether, intervening with medication change versus lifestyle change is going to be more beneficial for youth. And then, prevention of future cardiovascular disease is a huge research gap that we have in pediatrics. But getting back to the blood pressure measurement, I like the idea of CMEs. We do work with the American Academy of Pediatrics, and typically there are workshops at their, annual conference, and I'm in the middle of preparing a perspectives for the journal that may have some help, calling attention to the issue of blood pressure measurement. I think these are the things that we all need to do, no matter what segment of the age range we're sort of, addressing.
If I could make another comment, I think another aspect is really putting it in the place of community and people themselves. And so if, for example, like, again, I go back to pregnancy, but it could be applicable to a lot of places, like here's a form or here's an alert in your EMR, like I had a pregnancy related hypertension issue. It then flags it to like their PCP, like they need XYZ every single year, rather than like they don't get any care until, 4 years later when they have the next pregnancy or they hit menopause or they're geriatric or something like that. So letting people understand and know what really happened to them, and then that they may feel great, but hypertension can be asymptomatic a lot of the time. And so I think, again, interventions or trials where we focus on the person themselves, and maybe like self strategies or home surveillance strategies, and then also community partners. How can the community partners help?
Yeah, so thank you again to our panelists here for 3 great talks to get these discussions started. I do want to note that if you have a question and you are not a discussant or a moderator, you'll need to put that in the chat, and we'll try to get to those for future discussions. And so I believe we have a 10-minute break and we'll be coming back at 12:30, but I'm not one of the organizers, so I'll turn that over to the NHLBI crew for that.
Yeah, this is correct. So let us promptly return at 12:30. I'm sorry, at 1:30 or whatever are the timings, 12:30, 1:30, but in about 8 minutes, and get to session number 2. Thank you. See you then.
Recording stopped.
Okay, it's 1:30, so if, okay, it's break still, okay.
Okay, well, thank you, Paula. I'm Paul Muntner. I will be moderating this session along with Bev Green. Bev, would you like to introduce yourself?
Yes, I'm Bev Green, and I am a family physician and senior investigator, Kaiser Permanente, Washington.
Okay, thank you. And I will introduce the first speaker, who is Italo Biagioni. I apologize, hopefully I pronounced that correctly. And he will be speaking on position matters, orthostatic hypo and hypertension.
Thank you, Paul and Bev. I appreciate the invitation to speak to you all about these matters. Can I have the next slide, please? Next one. These are my disclosures, and we only have time for a very brief overview of these autonomic disorders. So I'm going to be highlighting the gaps and area that needs improvement as we go along, and those are in red. Next slide. So the distribution of orthostatic blood pressure changes follows normal distribution. And next slide, we focus on the left, the extreme on the left, patients that have a significant drop in blood pressure on standing or orthostatic hypotension. And the reason is easy to understand because these patients are very symptomatic. They can be able to walk only for a few seconds or minutes, and so it impairs functional status and quality of life. Importantly, it is associated with a significant risk of falls and disability in the elderly, and is also an independent risk factor for increased mortality. Next slide. But studies have shown also that the other extreme, orthostatic hypertension, is also associated with increased risk of cardiovascular and renal disease, dementia, and is also an independent risk factor for increased mortality. The difference being, of course, that these patients are usually not symptomatic. They are symptomatic with the exception of younger patients that we follow in our autonomic dysfunction centers with hyperenergic syndromes. Next slide. The pathophysiology of orthostatic hypotension on the left is basically impaired autonomic reflexes. You basically almost never have orthostatic hypotension unless you have some impairment of autonomic reflexes, and as Lou Lipsy described, that can be just by aging. And of course, those patients have a significant drop in blood pressure with very little or no increase in heart rate. And that's what we call neurogenic, the classical neurogenic orthostatic hypotension, because these patients don't have the ability to increase their heart rate to compensate for the drop in blood pressure. On the other hand, a lot of our patients do have some increase in heart rate, and some patients a significant increase in heart rate. And it's very important to measure that, not only the blood pressure, but also heart rate, because that tells us that there's some aggravating factors that need to be recognized and corrected, and that alone can improve orthostatic hypotension. On the previous slide. On the right side is the pathophysiology of orthostatic hypertension, and in the older hypertensive is the few studies, but very well done, show that it's aortic stiffness, and again in the younger patients that with hyperenergic syndromes, they tend to have sympathetic activation with vasoconstriction and a significant increase in heart rate. So it's very important to measure orthostatic vitals. Unfortunately, that's very rarely done, and that's one of the things that we need to improve on. And the other thing we need to improve is recognizing these aggravating factors for orthostatic hypotension. Next slide. So orthostatic hypotension is defined as a drop in systolic blood pressure 20 or more, or diastolic 10 or more within 3 minutes of standing. That definition has been around for a while, and so in a way it's time tested, and it actually is predictive of adverse outcome in clinical epidemiological studies. Next slide. The definition of orthostatic hypertension is more recent, and there's a consensus panel which I participated, and we propose a sustained increase in systolic blood pressure of 20 millimeters of mercury with an upright systolic blood pressure greater than 140. So we can argue whether the definition should be that strict or not. It does predict adverse outcome, but that's something that probably needs some refining over time. Next slide. So the is that orthostatic hypotension is an actionable finding, and orthostatic hypertension is what do we do with this finding. But I think there's research that we need to do to define these things. Next slide. So in terms of management gaps, and I apologize, but this arrow should have been on the left side, but that's okay. So the challenge, you can understand that there's a challenge in treating orthostatic hypotension in patients with hypertension, which, by the way, are the most common clinical finding. Most patients with orthostatic hypotension will have some hypertension, sometimes very severe. So what medicines can we use to treat orthostatic hypotension without worsening supine hypertension? And that the medications we have to treat OH, the worst of them are florinef and midodrine. They will worsen supine blood pressure a lot more than they will improve standing blood pressure. Droxidopa is a little bit better. And those are the only two FDA-approved drugs, midodrine and droxidopa. So, and they both have a black box warning for supine hypertension. So we need to develop other medications that will do a better job. Pyridostigmine is probably the best for that, but it's not that very potent. And the studies we have done recently is less effective in patients with hypertension, which is where they will be mostly needed. There's new studies done with NET inhibitors, like atomoxetine and others that are being developed that might be helpful. And there's countermeasures that selectively improve standing blood pressure. Next slide. So how can we treat hypertension without worsening orthostatic hypotension? So in the majority of hypertensive, now there's evidence that you should not stop antihypertensive, which is a very common mistake, and that you can do intense blood pressure control without triggering orthostatic hypotension. Unknowns are if some antihypertension should be preferred more than others. And there's a list that we've published with Stephen in an American Heart guidance document. But they make sense. There's some rationale for it, but it would be good to have some validation. Next slide. Now, it's important to realize that in those studies, patients with significant orthostatic hypotension were excluded from those studies. And there are some patients that have severe orthostatic hypotension and hypertension. And the interesting thing is that the supine nocturnal hypertension induces daytime orthostatic hypotension because the supine blood pressure induces pressure diuresis. A lot of our patients lose 1 to 2 kilograms of weight during one night, and therefore their orthostatic hypotension during the days is worse. So next slide. So this summarizes 25 years of work. Here we've tried a number of medications to reduce nocturnal hypertension, and a lot of them do that. But none of them reduce pressure diuresis, and none of them improve morning orthostatic hypotension. But once we've targeted capacitant vessels, either the skin with local heat with a heated mattress or splanchnic circulation with CPAP, continuous positive airway pressure, now we're able to control nocturnal hypertension, reduce pressure natriuresis, and improve daytime blood pressure. But these are acute studies, and long-term efficacy is to be determined. Let me stop that because of time constraints, and be happy to answer questions in the panel session. Thank you.
Thank you for a fantastic presentation. We can go to the next. Okay, thank you. So next we have Dr. Dart, who will be speaking on the measurement of blood pressure in the obese and weight loss, the clinical challenge. And so without further ado, I'll turn things over to Dr. Dart.
Thanks, Paul. And thank you. I'm Dick Dart. I'm at the Center for Precision Medicine, Marshfield Clinic Research Institute, and the Marshfield Clinic Health System. Next slide. These are my disclosures. I am on the AMA subcommittee on sphygmomanometers and the USA representative of the ISO sphygmomanometer committee, and also chair of the ISO large arm definition task force and motion artifact subcommittees, and also a member of the AMA validated device listing review committee, but I have no other conflicts. Next slide. While it was von Recklinghausen in 1901 who criticized Rivarocci that he had made an error in the size of the cuff he had for his blood pressure device, that it read blood pressures too high. It actually was Richard Day in the Journal of Pediatrics in 1939 who indicated that one should select a cuff from the widths given readings on the flat part of the curve, and for practical purposes, this means the use of a cuff which is as wide as will fit the arm without impinging on the elbow and axilla. And that latter 2 points are ones that I'm going to be emphasizing as we go on. Next. So the problem we face with a large or obese arm is there is no universally accepted definition for large arms, not really. There are definition proposals, some of which I'll be discussing, and the manuscript is also in progress, and that was the large arm task force as noted below. Does the large arm apply only to adults, or does it include children and adolescents? And I think it's an emphatic yes, it implies to children and adolescents. As Dr. Flynn noted, they grow up and grow out, but by the time they get to us, they've grown up and all they do is now growing out. So the problem comes, it remains a clinical challenge for how best to measure blood pressure in very large arm patients, as O'Brien once noted, and as Palatini and Parati also have commented recently. Additionally, amongst many articles, Steve Jurashek recently commented on one of the many examining of existing cuff systems, and the errors in American Heart Association guidelines exists over a wide range of arms and sizes, and noting the need for a proper cuff in systems and validation studies. Next. So the universal standards for blood pressure validations really at this point have used about 42 centimeters or larger for arm circumference as one definition. However, we are proposing a much more defined consideration with the mid-upper arm circumference, which varies over a wide range and is not limited to an upper size, though generally is going to be up at least somewhere around 50 to 55 to be a truly large. The inner arm upper length, the age is physical and stature dependent, is a part that is not generally done but is measured, but comes into play with some of the recent stuff that Palatini and colleagues have done. Additionally, there's been refinement of the truncoconical versus cylindrical shape of the arm and the arm slant angle. So there are 4 components that really define large arms or arms in general, but particularly apply to large arms. Next slide. Now, one of the things is the bladder width to arm circumference ratio, which everybody knows about, but it was first described or at least codified by Geddes and Tivey, Geddes and Worcester in 76 and 78, taking mostly auscultatory data and using a sweet spot of about 40% of the arm circumference with a bladder width that would be adequate to do correct blood pressure readings. More recently, March and Grosch took this a bit further using radial artery blood pressures to compare the arm circumference width ratio, and it came out fairly close to this 40%. And that was supported by Alpert. It would have been nicer to, as he notes, to use brachial artery studies, but that is not reasonable in a clinical setting. The critical issue is really the sweet spot for the most accurate blood pressure lies between 37% and 50% of bladder width to arm circumference ratio, and that was recently adopted in the ISO standards to improve accuracy in blood pressure devices manufacturing. However, BWACR is not the sole parameter required for cuffs to obtain accurate blood pressure measurement. Next slide. And this, very briefly, is a slide that shows that the inner arm length, or for the arm circumference, and I want to go to the next slide in a better showing of this, shows a virtual linear condition between the inner arm length, upper arm length, and mid arm circumference, below which any cuff that would be in this area will not be able to be used for an auscultatory reference. It's going to come over the tip of the antecubital fossa and likely not fit up into the without pressing up into the axilla. Next. So the next component is the truncoconical shape of the arm. And this was really first described by Steinfeld et al. In 1974. They designed a trapezoidal cuff to accommodate such arms. However, it did not get much traction. It wasn't further evaluated by them per se, but Huygens, Arzanius, and others over several years studied the accuracy of special truncoconical shaped cuffs, and they showed them to be more accurate in large arms than the cylindrical cuffs. However, it was actually Maxwell and more recently Palatini and colleagues who really have published numerous studies, especially designed truncoconical cuffs. Yet the best cuffs for the large arms in adults remains to be elusive, though it's considered a significant step forward, as was noted by Tammy Brady and Andrew Taylor. And the anthropometric use of the data that generated these cuffs that Palatini and colleagues have developed. The recent study that mentioned by Dr. Flynn earlier, done in pediatrics, there were only 7 children in which the truncoconical, large truncoconical arm was used, cuff was used, excuse me, and they didn't find a difference. That has not been proven with the case with Palatini in adults because they've used thin paper-thin sensors under the special cuffs to assess for even pressure distribution in the truncoconical cuff, and it works much better than the cylindrical one, and it suggests that this cuff might serve as a validation cuff, yet that there's a good bit more work to be done in this. Next slide. And this is why it makes it a little easier to understand. If you think of an arm as cylindrical, and a cuff fits around it, that's going to be fairly symmetrical at both ends. As the arm gets a little larger, that cuff begins to get a little bit more expanded at the upper end, but by the time you get to the very large cuff, a cylindrical cuff just clearly physically cannot satisfactorily encase this kind of an arm, and that is one of the reasons why we are proposing a truncoconical component to cuffs for larger arms. Next slide. So this then turns us to the problem of obesity and overweight. And I was alluded to by Dr. Flynn, obesity and overweight have been increasing for decades. It's increasing worldwide. There's concomitant comorbid diseases beside blood pressure. There's type 2 diabetes, cardiac and renal disease, and the effect of obesity as a causal factor in blood pressure is high blood pressure is complicated. It's not the focus of this presentation, but I will mention that the reference I looked at, which was by Hall et al. In Brownwald in 2024, is an outstanding review of the complex interactions of obesity in hypertension and related diseases. It has an impact on the cuff size requirements, and the effect of weight loss on blood pressure will be something else that we will briefly touch on. Next slide. So as previously noted, Jackson et al., using data from the NHANES study, noted that there is an increase in the large arms, particularly in the 44 centimeter and larger arms that are occurring in the population. And I will show in the next slide that this is beginning to show up more and more, both in children, as Dr. Flynn pointed out, and I think it was worth re-emphasizing that between 6 and 9 and 16 and 19-year-old children, they're going from adult to a large adult to even thigh cuffs, and this is down here in kids that are 16 to 19-year-olds. Those are big cuffs. So this is affecting children as much as it is adults. Next slide. In regards to adults, the adult large and extra large cuffs You can see that the numbers are much larger with adult cuffs, but they drop a little bit to 97 million or about 8 million with the very large cuffs. And although the slant angle gets more decreased more as arms get larger, there is a splay in these arms in terms of their ability to have accurate blood pressure, and possibly because of the inner arm length on some of these patients, these subjects being somewhat larger than in other than some other ones, so that you get this large splay. Next slide. So the model for the large arm cuff bladder system, well, we don't really have one yet, but there's limitations to the special troncoconical cuff, because there have been small numbers of subjects that have been studied in the extra large arm groups. There's a need for further studies. The results are likely going to be valid, as Palatini and his group has said, and it's not by chance by what they get. Notably, they excluded patients who had less than 20 centimeter inner arm length, and the use of a cuff of appropriate length was not possible, was not possible, and these were the smaller arms. And this resulted in about 5.5% of their extra large population that was studied that had this axilla to antecubital fossa distance that was less than 20 centimeters. In the real world, Paulo has suggested that there are going to be many more such arms if women and older adults and shorter people are considered, and in larger populations. But they propose that this cuff system might be used as a reference cuff for arms at least 43 to 50 centimeters mid-arm circumference. Again, if they are not in this antecubital fossa axilla ratio of less than 20 centimeters. Next slide. Next slide. Okay, thank you. So obesity and high blood pressure and weight loss is a very complicated thing, but is part and parcel to the issue of what we're dealing with in this population, where we are trying to find cuffs that will give us accurate blood pressure readings. These are associated with, as I've already pointed out, with comorbid disorders, which are very expensive and costly to treat. And the exact cause and effect of obesity and high blood pressure is not totally known, but it's multifactorial. In this nice review that includes such things as visceral adipose tissue, subcutaneous adipose tissue, endocrinologic, metabolic, gut microbiome, inflammatory components, salt, and other factors associated, but not yet fully clarified. Next slide. So if we get an approach to weight loss, is this going to impact things? Well, a couple of points is that there are medications. They can be effective, but they have a lot of side effects, and there's not very much in the way of long-term use. In fact, most patients stop using them. They have to because of side effects. There are surgical interventions, and many of them are very effective. However, if you consume the wrong kinds of food, such as lots of malted milks, etc., you can get around them. We all know that exercise is very effective, at least in some aspects of both improving cardiovascular health, but also reducing weight. And we know that the DASH diet is associated with at least an 8 millimeter mercury systolic drop. Mediterranean is a 2 millimeters systolic drop. But as Steve Jurashek and his group have shown, the DASH plus low sodium intake in some population of greater than 150 systolic got at least a 10 millimeter drop of mercury, which is really quite remarkable. But the problems with it is the sustainability. Next slide. Next slide. So
else on that prior slide. I guess it got cut out, unfortunately. So what I had here was that the KDIGO guideline specifically recommends in people with chronic kidney disease that the blood pressure treatment threshold should be less than 20. This is based off of similar evidence as what the recommendations were for the 2017 ACC/AHA guideline, but I think it's specifically recommended for a few reasons that I'll talk about on my next slide, please. Next slide, not back, please. There we go. That was the bullet point. Next slide, please. Thank you. And so there's a lot of rationale for why I think there could be this discrepancy. KDIGO recommends this more stringent blood pressure, first of all, on hinging on requiring standardized office blood pressure. Other recommendations also recommend this, but they try to be even more stringent about it. Additionally, there's this disproportionate cardiovascular risk in people with chronic kidney disease, where our patients tend to all ubiquitously be at elevated risk for cardiovascular disease. Chronic kidney disease is considered its own independent cardiovascular risk factor. And so because the main goal of lowering blood pressure in these patients is that reduction in cardiovascular risk, not really a kidney protection. If anything, sometimes we'll see more of this therapeutic hypercreatinemia as we escalate treatment, where have the rise in creatinine, but lowering of cardiovascular risk. And so this really may be distinctively why KDIGO pushed so much for that lower blood pressure goal. Additionally, patients with chronic kidney disease are often excluded from blood pressure trials, and I'll talk a bit about the implications of this in people with more advanced chronic kidney disease who really aren't included in that KDIGO recommendation. If you dig deeper into the KDIGO guideline, when they discuss people who are close to starting dialysis or on dialysis, we really don't have any guidance in what their blood pressure goals should be, even though these are our patients who are at the highest risk of developing major cardiovascular events. And then there's also the question of whether it's just interpreting the achieved versus the assigned blood pressure goals in trials, and that the KDIGO guideline recommenders basically were more stringent in saying, well, SPRINT assigned people to a blood pressure goal of less than 120, and that's what we should be recommending for our patients, understanding that there could be a slightly higher risk of adverse events that's superseded by their excess cardiovascular risk. Next slide, please. And so there are some really important distinctions, particularly in blood pressure assessment, which was what I was tasked with discussing in people who have chronic kidney disease compared to non-chronic kidney disease populations. First and foremost, as has come up previously when talking about pregnant patients, there are particular challenges with blood pressure measurement accuracy and device validation in patients with chronic kidney disease. There are no guidelines that recommend distinctive blood pressure validation in CKD as its own distinct population. However, these patients are much more susceptible to having broader oscillometric waveforms, which can be differentially interpreted by these devices and may result in different validation, meaning that in a couple of studies that have tried to validate blood pressure devices in chronic kidney disease populations and dialysis populations, which have been validated in non-CKD populations, they found that the devices often are not accurate. And it's not clear if this could be related to some issues with actually being able to perform the validation protocols perfectly in those populations, or if it's really the fact that they have different blood vessel characteristics that are known to impact that oscillometric wave envelope that's used to extrapolate blood pressure information from these automated devices. Our patients also have a higher burden of arrhythmias than most patients in the general population, and this could contribute to difficulties with getting accurate blood pressures, more so than in the general population. And they also have a lot more interstitial edema broadly, which can create issues with blood pressure accuracy and accuracy of the cuff's ability to get an accurate blood pressure. Additionally, our patients in general, when we try to assign them to self-monitoring of blood pressure, have much more difficulty broadly with self-efficacy and uptake of interventions for many reasons, in part due to high comorbidity burden and polypharmacy, in part due to the fact that these patients are often of lower socioeconomic statuses and often have lower health literacy. And so these are really distinctive challenges, more so than in many other populations. Additionally, chronic kidney disease is a major risk factor for mast hypertension. Paul Draws has done a lot of the work showing this. About a quarter of our patients are found to have mast hypertension before starting dialysis. And we don't have any data on outpatient or out-of-office treatment targets in people who have a normal office blood pressure in all these randomized control trials using office automated blood pressures, but have an elevated blood pressure the rest of the time. Next slide, please. And then hemodialysis opens an entirely new can of worms. People on hemodialysis, unfortunately, have even greater challenges in getting accurate blood pressure measurements. Peri-dialysis blood pressure, meaning the dialysis unit blood pressures that are performed before, during, and after dialysis, have been the classic targets for volume management and antihypertensive therapy. As a dialysis provider, I can't tell you how many phone calls I get on a regular basis asking for titrations and dry weights and blood pressure medications based off of these readings, and there is a large volume of these readings. And they're often taken while the patient's supine, over clothing, getting stuck with a needle and in pain or fearing the pain that's about to happen, with a lot of substantial ambient noise in these dialysis units, with alarms constantly going off, similar to what you would get in an intensive care unit, often with poor anatomical placement because many of our patients have had multiple arterial venous fistulas and no longer have a limb to obtain a blood pressure from, and you're getting an arterial brachial index or an ankle blood pressure, essentially. And many of them have volume overload that's often much more complicated and often worse than in the pre-dialysis population. There's also, again, a lot of confounding from comorbidities. For example, many patients are preload dependent. We see a high proportion of individuals with severe aortic stenosis, with cirrhosis, other issues that create an issue where your blood pressure can very, very quickly plummet as soon as there's fluid removal occurring on dialysis. And then many of these patients who often no longer urinate or urinate a very small amount, where their blood pressure can vary a great deal over the 44-hour period between dialysis sessions, and that's historically been what's done to collect their out of dialysis blood pressures. But it's very poorly tolerated to do ambulatory blood pressure monitoring for that long, and in patients with so much comorbidity burden and other disease burden. They do tolerate home blood pressure monitoring quite well. This is an example of a semi-qualitative mixed method study that we had performed, where we found that these patients really, really loved doing home blood pressure monitoring, felt empowered by it, and were able to do it. But it's really underutilized. And dialysis providers, when given home blood pressures, really don't know what to do with them and have not been acting on them historically. Next slide, please. And so, in summary, we really don't have sufficient evidence to guide blood pressure targets in these patients. Peri-dialysis blood pressure is the classic target of volume management and antihypertensive therapy, but it's really suboptimal based on epidemiologic data. Out of dialysis blood pressures, particularly home blood pressures, may be a better way to target or a better option to target than peri-dialysis blood pressures when individualizing treatment strategies, but there's very little data in this area. I'm currently a co-investigator on a multi-center trial that's just starting to scratch the surface of understanding the safety of doing this and the feasibility and whether patients can uptake this, but there's a lot more work that needs to be done. Next slide, please. And so to conclude, I think that there are several key knowledge gaps and future opportunities in this space. In terms of the gaps, we really don't know whether separate blood pressure device validation is required in people with chronic kidney disease, what the optimal blood pressure treatment targets, setting, and approach should be in dialysis patients in particular, the appropriateness and identification of out-of-office treatment targets in our patients, which could potentially be different than in the non-CKD population because of this markedly higher cardiovascular risk burden balanced with adverse effects and self-efficacy and other issues, and approaches to improving implementation of office and home blood pressure measurements, focusing on the distinctive needs of these patients with those issues in mind. Last slide, please. Or next slide. Oh, okay, I think my last slide is skipped, but that's all right. I had a future opportunities. Thank you. And so I think that specifically the future opportunities are in developing trials and observational studies that'll focus on these main gaps, particularly broadening the inclusion of chronic kidney disease patients in trials because of their exclusion so frequently from trials. We really don't know how to treat these patients, especially those with more advanced chronic kidney disease, or at least developing trials that will focus on them to gaps. So thank you very much.
Thank you, Jordy, for an excellent talk. I have a lot of questions. I hope our audience does too. Put them in the chat, please. Our next speaker is Adam Bress, who is a doctor of pharmacology at the University of Utah and a pharmacoepidemiologist. And he's going to speak about blood pressure as a critical vital sign transitioning from hospital to home settings. Thank you.
Great. Thanks so much, Dr. Green. It's really a pleasure and honor to be here today with such esteemed leaders and experts and friends. I've already learned quite a bit. So my talk is on blood pressure as it relates to the hospital to home transition. Next slide. And, as we've heard from Dr. Goff and all the other talks, we know that high blood pressure is the leading cause of cardiovascular disease and is also an emerging cause and risk factor for cognitive decline and dementia. And the context for my talk is, despite the widespread availability of safe, inexpensive, effective antihypertensive medications, blood pressure control rates could be higher, particularly in groups that don't have a regular healthcare provider or usual source of care. And the additional context is there are about 36 million hospitalization events in the United States each year, in which many blood pressure values and readings are taken and perhaps utilized for care. And these blood pressure readings could be elevated for numerous reasons, for underlying hypertension itself, could be because of an inaccurate measurement, could be from an iatrogenic cause such as medications. It also could be elevated because of stress from the acute illness or the physiological process, or perhaps sleep deprivation. So with all that, my talk is next slide is going to talk about what's the state of the evidence and perhaps the guidance for what to do with all these blood pressure readings in the hospital. And while there is a lot of evidence, a lot of really good evidence, a lot of randomized evidence and guidelines for the management of hypertension in the outpatient setting, there's very little high quality evidence, best practices for how to manage blood pressure in the inpatient setting. We don't really have good evidence to tell us what should we be treating high blood pressure with medications during the hospital, and what to do at discharge in the absence of hypertension emergency, where there's signs and symptoms of new or worsening target organ damage. But in the context of asymptomatic hypertension, there's very limited evidence on what to do. So the next slide. So I had the honor of leading an esteemed group along with my co-chair Tara Chang to review the literature and to create some frameworks and perhaps highlight some best practices and evidence gaps for the management of elevated blood pressure in the acute care setting. And it was published last year in Hypertension. And the committee really co-created a pretty comprehensive document. And the committee included a diverse group of clinicians and scientists from hospital medicine, cardiology, pharmacy, nephrology, nursing, emergency medicine, and others. Next slide. And I do think there's 2 points of view on this. There's one point of view is that there is a case to be made that the hospitalization may be a good time to identify individuals with undiagnosed essential hypertension. And for the reasons I mentioned before, this may be challenging. It also may provide an opportunity to optimize poor quality regimens, particularly patients who don't have regular access to care. And there's more on this later. Next slide. So the committee did think a lot about the causes of elevated blood pressure in the acute care setting, and we organized them into patient factors and hospital environmental factors. Next slide. And there's 2 hemispheres on this figure that was included in the report. And the patient factors are in the northern hemisphere, the green, and the hospital environmental factors in the blue, and some that are a little bit of both. So we have the clinical condition, volume overload, thyroid storm, could be uncontrolled chronic hypertension.